Ladies and gentlemen, good morning. Welcome to today's webinar entitled Diversity and Gender Equity in Health Research. Please allow me to take this opportunity to introduce to you Ms. Nandi Ncube. Nandi, she is the Regional Stakeholder Engagement Manager at AVEC. She is also a Regional Stakeholder Engagement Advisor and provides a technical content-focused support to AVEC's research engagement activities with a special focus on activities in the East and Southern Africa. Nandi has joined AVEC in December of 2019 and brings with her a wealth of knowledge and experience managing community and stakeholder engagement programs in the biomedical HIV prevention research fields. 5 years of which were spent working for the HIV Vaccine Trials Network, or HVTN, where she led the HVTN's community and stakeholder engagement program for the Sub-Saharan Africa region. In 2006, Nandi was one of the recipients of the Omololu Falobi Award for Excellence in HIV Prevention Research, Community Advisory. Nandi, she's a passionate advocate for the needs of girls and young women in her community and is a GPP Maven. She holds a bachelor degree of social science from the University of Natal in Media and Communications and Political Science. She also has a postgraduate diploma in Industrial Relations from the University of KwaZulu-Natal. Nandi, it gave us a pleasure and privilege as the SATEC Secretariat that you have taken time to be with us today to moderate today's sessions. We welcome you. Over to you, Nandi.
Thank you so much, Mr. John Mdluli, for that wonderful introduction. Good morning and a warm welcome to today's webinar on diversity and gender equity in health research and development. This webinar was put together by the South African Health Technologies Advocacy Coalition, also known as SATAC, in partnership with PATH and Campaign for Cancer. The purpose of the webinar is to discuss and understand the barriers, challenges, and how to achieve diversity and gender equity in health research and development. The aim is also to understand and explore how we can promote equitable access to health products. Before we start, I think it's worth noting that the United Nations Sustainable Development Goals, which support the implementation of universal health coverage by 2030, recognizes that more equitable and timely access to health interventions, such as medicines, vaccines, diagnostics, and therapies, is an important driver to good health and improved lives. The COVID-19 pandemic has exposed the disparities that exist between the wealthy nations and low-income settings nations in the lack of timely access to COVID-19 vaccines and medicines. There is therefore a need for us to address the lack of equitable access to health products in South Africa. It is for this reason, amongst others, that SATAC, PATH, and Campaign for Cancer are hosting today's webinar, which is to discuss the barriers, challenges, and facilitators to achieving diversity and gender equity in health research and development. Before we start, I'd like to request and invite you all to kindly introduce yourselves in the chat by telling us your name, surname, the organization that you work for or are affiliated with, your role in that organization, as well as the area where you're based. Again, my name is Nandi Ncube, and I'm with AVEC as a Regional Stakeholder Engagement Manager, and I'm based in Johannesburg, South Africa. We have a very exciting agenda that will be led by 3 expert panelists, Ms. Nonhlanhla Sibanda Moyo, Mr. John Paul Omolo, and Professor Hedi van Ruan, that will help us understand what is meant by diversity and gender equity in health research and development, that will talk about product development and how products are prioritized and influenced and who influences the research agenda, as well as how to achieve equitable access to health products. These presentations will be followed by a live discussion or a Q&A session where you will all be encouraged and invited to ask our panelists questions directly. Please use the chat or the Q&A function or raise your hand or the raise hand function to put forward any questions or comments you might have for our panelists. And we'll make sure that all your comments and questions are addressed during the Q&A session. Also, please remember or don't forget to keep your line muted if you're not speaking so that our line is clear. Without any further ado, I'd like to introduce our first expert panelist, Ms. Nonhlanhla Sibanda Moyo, who is a gender specialist and a public policy analyst. Ms. Sibanda Moyo has over 15 years experience in the gender and women rights sector, specializing in gender mainstreaming and integration. Specifically, she has conducted gender audits, gender analysis, and developed gender action plans and policies for various institutions. Some of the work she has done includes conducting a gender analysis for the South African National Biodiversity Institute and supporting the process of developing their gender action plan. In 2020, she developed a training manual on gender mainstreaming and infrastructure development, finance, and facilitated the virtual training of staff members from the Development Bank of Southern Africa. Ms. Sibanda Moyo was also selected to serve in the expert roster on women empowerment and gender equity in UN Women from 2020 to 2022. She holds a master's in public health policy and 2 honors degrees in gender and transformation studies and in development studies. Ms. Nonhlanhla is going to introduce us to diversity and gender equity in health research and development. Over to you, Ms. Nonhlanhla Sibanda Moyo.
Thank you very much, Nandi, for that introduction, and a very good morning to all participants to this webinar today. So the purpose of my presentation, and I'll ask that Michaela, please put it up on your end, put up the presentation for me from your end. So the purpose of my presentation today really is to initiate a discussion on diversity and gender equity in health research and development. And I really would like to invite all of the participants today on a journey with me to explore what I consider an incredibly important topic in trying to understand how diversity and gender equity impact on health research and development. I am not seeing the presentation on my end. Michaela, are you putting it up?
Can you see the presentation now?
Yes, yes, please do put it on slideshow. Thank you. We can move on to the next slide, which shows an outline of my presentation, which will really focus on the specific areas that are highlighted. So I am going to look at whether gender really matters in health, and also look at defining sex and gender, and briefly just give an overview of some of the international policy frameworks that govern gender equality and health. And lastly, I will also look at the importance of gender and diversity considerations in health research and development. Next slide. So you will note that as part of the registration process for this webinar, we did request you to fill in a survey, and I am really excited to share some of the interesting results that came out from the survey. So we asked participants if they thought that gender and diversity were relevant to health research and policy work. And over 80% responded in the affirmative, with about 20% saying that these concepts are not relevant. very, very interesting results there. And similarly, about 72% of respondents indicated that gender and diversity are not relevant to the mandate of their organization or institution. And I want to say that the 18% who responded that gender and diversity are not relevant to their organizational mandate or everyday work are definitely in the right place today. And I'm very optimistic that by the end of this presentation, we would have reached some sort of convergence or agreement that everything in this world is gendered. So let's see how this relates to health and health research in particular. We can move on. So here we want to build a case as to why gender and diversity matter in health. And in order to do this effectively, we need to start by defining key concepts. So we need to be in agreement. We need to have a shared common understanding of the key components, key concepts that relate to this topic. What exactly do we mean by gender and what do we mean by sex? And I know that a lot of times we tend to collect these or to use them interchangeably because we think they mean the same thing, and they don't. In simple terms, sex is what we are born with. It refers to the biological features that we are born with. For example, the fact that women bear children and men have testicular cancer and so forth. Gender, on the other hand, is a social construct. It is what we are given, or the roles, the responsibilities, and characteristics that society ascribes to women, men, girls, and boys. For example, that we often say that men are providers and women are nurturers, and women were pink and men were blue. So those are the ideas that make up some of the ideas that make up gender. We can move on. So as we move along, I would like us to delve a little deeper in terms of explaining what sex really is and what its implications are on health research, because that's what we are discussing today. And to start off, I want us to dispel the myth of the binary of sex. That is the misconception that there are only two sexes, that is male and female. I think science has shown us that sex goes beyond the binaries of just female and male, but rather sex is more fluid than that. And for example, we do have intersex persons. And when we talk about diversity, we also need to talk about diversities within the context of sex. And now, having established this, how does sex impact on human health? And research has claimed that every organ in the body has the capability to respond differently on the basis of sex. And the male and female bodies have different physiological and hormonal differences that result in different responses to, for example, alcohol, to drugs, and to treatment. Research has also shown us that the typical female body has inherent differences when compared to the typical male body. And this ranges from cellular metabolism to blood chemistry. And now, in light of these variables, it then becomes very important to include gender diverse groups when conducting either biomedical or clinical research. And this is because results cannot be generalized or applied across different groups. Let's move on to the next slide. So now, moving on to gender. As I earlier indicated, gender is a social construct, and it prescribes what it means to be female and what it means to be male based on a given society. And also what is important to note is that gender is hierarchical. That is, it places more value, it tends to place more value or importance on masculine characteristics or certain male groups over others. Again, we also know that gender is historical and it changes over time. So it's dynamic, it's not a constant phenomena. And as per the quotation that I put on the slides by Loba and Farrell, because gender is built into the social order through major social institutions of control, such as law, such as medicine, politics, this often leads to the differential treatment of women and men, and also other marginalized groups. And as a result, this tends to have an adverse impact on health. Next slide, please. So to conclude this particular part of the presentation, we have established the following. We have established that both sex and gender matter in health. And this is because of the biological differences between women and men. And these on their own, the biological differences on their own, again, are not enough to explain these different disease patterns. So merely just looking at sex or the biological differences is not enough. We also know that from a gender perspective, there are differences in life chances and gender norms for women and men. Again, health differences for women and men exist beyond sexual and reproductive health. And because of this, if we do not take into account sex and gender differences in health, if we do take into account sex and gender differences in health, we can to some extent mitigate or prevent adverse health outcomes. Next slide, please. So this slide further elaborates on the different health needs of the gender diverse groups, which can be a result of biological differences. For example, women and men are often susceptible to different illnesses. For example, prostate cancer for men and cervical cancer for women. And again, from a gender perspective, women are said to be twice as likely to suffer from depression. And women are also more likely to experience violence and abuse in relationships. Again, we also note that gender diverse persons might also be affected differently, as research has suggested that transgender persons tend to experience high levels of mental health challenges that are linked to discrimination and stigma. Next slide, please. So this slide speaks to the reality that while sex and gender may seem mutually exclusive, oftentimes we want to look at them as exclusive. In reality, these two concepts are interrelated and they intersect. And as a result, there needs to be agreement on the definition of sex and gender that can be used across different fields, including health research. And these definitions need to be used accurately. Next slide, please. And we have already established this. We've established that gender is a determinant of health. And while gender inequalities usually have a disproportionate burden on women and other marginalized groups, negative social norms can also negatively affect men's health. And also a good example is men's limited health-seeking behavior. Next slide, please. So I want to then quickly move on to discuss the legal and policy framework on gender equality and health. Next slide. We can move to the next slide. So the right to health is enshrined in the South African Constitution. And this particular right, I think, needs to be read together with the equality provisions in the Constitution. So the right to health is very much entwined to the right to equality. Because when we talk about gender equity within the context of health. This means that everybody has an opportunity to attain their full health and well-being according to their respective needs, with no one being disadvantaged as a result of gender norms, roles, or relationships. Next slide, please. So at the national level for South Africa, the right to equality is enshrined in the South African Constitution and also in the Bill of Rights. Again, South Africa has a national gender policy framework which further outlines South Africa's vision for gender equality. So there's a lot that the health research sector can draw from in terms of the national gender policy framework, in terms of how to ensure that health research is gendered or takes into account gender considerations. Next slide, please. So on the slide, I have listed some of the international policy instruments that South Africa has acceded to or has ratified and committed to in terms of promoting the gender equality agenda. I'll not really delve much into them. I think that's a whole conversation for another day. But I think what's important is that because South Africa has made these commitments, it is important that we acquaint ourselves with these instruments and their provisions, so that we are then able, as civil society or as citizens in our respective portfolios, we're able to hold government accountable to the effective implementation of these policies. Next slide, please. So this slide also makes specific reference to some of the provisions in the Sustainable Development Goals that relate to health and the well-being of all, particularly SDG 3 and the SDG that relates to gender equality, and how these are codependent. And there's a whole lot to say on this, but given the limitations of time, I will leave this here. Let's make this a conversation for another day. But as you see on the slides, these are some of the provisions or considerations made within the Sustainable Development Goals that call for the need for gender equality and gender equity within health. Next slide, please. So as I come to a close in terms of my presentation, these are some of the concluding thoughts that I would like to leave the participants with. Why is gender equity crucial to health research? So firstly, both scientific and biomedical research are more accurate or would be more accurate if they took into consideration gender and sex. And again, ethically, it is important for research to account for the biological and social differences between men, boys, girls, and other gender diverse persons. And again, we also note that most research tends not to consider sex or gender as variables and tends to treat men as the norm. And this results in different health and safety outcomes for women and men. So this needs to change. And again, for products to be safe and effective, they need to be tested on the diverse gender groups. Science can also result in cost savings for the healthcare system and more effective policies and programs if we take gender equity into consideration. And finally, the lack of interest in sex and gender differences may not only be harmful, but also present missed opportunities for innovation. There is therefore a clear need to strengthen our collective efforts to work together to ensure that the promotion and integration of sex and gender as a standard practice in health research. I think I will end here, and thank you very much.
Thank you so much, Ms. Sibanda Moyo, for a very important and informative presentation. I'd like to remind you all to kindly use the chat or the Q&A function to put forward any comments or questions that you want to pose to our expert panelists. And also feel free to use the raise hand function to raise your comments and ask any questions directly to our panelists. Up next, we have Mr. John Paul Omolo, who is going to take us through the process of product development, particularly focusing his talk on what products are prioritized and who influences the research agenda. Mr. John Paul Omolo is a public health professional and a health policy analyst with a vast experience in health system strengthening and health policy advocacy. He has extensive expertise in health policy formulation, monitoring and evaluation, health system strengthening, and program management. Currently, he is the Health Research and Development Officer at PATH. Before joining PATH, Mr. Omolo was the National Coordinator of the Health NGOs Network, also known as HENET. And before that, he served as the Health System Strengthening Officer at LVCT Health and the Quality Control and Quality Assurance Officer in an influenza effectiveness study at the Center for Disease Control and Prevention, the CDC. Mr. Omolo was a member of the Universal Health Coverage Health Benefits Advisory Panel, which was a team that was charged with the responsibility of designing an affordable, responsive health benefits package for the delivery of universal health coverage in Kenya. He also serves as a member of the African Medicines Regulatory Harmonization Partnership Platform. He previously served in the Global Gavi CSO Steering Committee and the Global Financing Facility Civil Society Steering Committee. He also holds a master's in public health. Over to you, Mr. Omolo.
Thank you so much, Nandi, and my appreciation to all the organizers for this opportunity to talk about diversity, equity, and inclusivity, and within it, gender integration, gender mainstreaming in health research and development. I'm really privileged to be part of this team on my own behalf and that of PATH. I might want to just put in a timer because I know my time is limited for this. So I think in speaking to the topic of the day, looking at gender and the other aspects of diversity, equity, and inclusivity, which for the sake of this conversation, I'll be calling it DEI, considerations in R&D. I wanted just to raise the profile because sometimes when we speak about things, we assume that everybody knows what R&D is. So I'll take this first opportunity just to quickly to unpack what R&D is. And as we all know, research and development is the translation of an idea or a discovery into a product that addresses a health need. And in global health, the end result should be a safe, an effective product, or sometimes if it's a drug, we say it's efficacious product that is appropriate and affordable, acceptable, and accessible to those who need it most. And it is important that at this point we look at why do we say it should be appropriate? Why should we say it should be affordable? Why should we talk about acceptability and accessibility to that matter? And the issues of gender then kicks in at this point because things cannot be appropriate, affordable, acceptable, accessible if gender and other aspects of DEI are not considered from the very onset of producing this product. The development of these new health innovations should usually result into, reduced deaths, reduced treatment, because as Ms. Sibanda Moyo has mentioned, and sufficiently also improve social and economic outcomes. Research and development is essential as part of solutions to the world's greatest global health challenges. Like now we are having COVID-19, and it drives health improvements globally. And therefore, in the progress against existing and emerging threats, we require research and development. And in developing this, we need to have everybody on board. Therefore, health research and development in its entirety has a multiplier effect. It not only saves lives, but it also improves lives, but also creates cost savings and drives economic growth, as well as enhancing global health security. So having talked about what R&D is, health R&D is, when we want to talk about why is it important to consider and incorporate key gender and broader DEI considerations into research and development, it is important that we start thinking with the end in mind. So we may not talk about and we may not all understand what R&D all entails until we see it from the end perspective. Where does it matter most? The first thing I would like to talk about is the issue of the health equity, that is quality and safe. Issues of equitable access to health. And within it, we talk about quality and safe. So most of the current health R&D efforts are targeted to address the health needs of the most vulnerable populations. And when we talk about most vulnerable, point in case HIV, TB, malaria, and even COVID, women and girls fall within this category of the most vulnerable populations. And we are going to see why we continuously call them vulnerable, but we do very little to address the issue from the root cause. The second thing where it matters most is the fact that when we talk about universal health coverage and leaving no one behind, when one of the tenets of UHC is the fact that we talk about leaving no one behind. So within that spirit of addressing universal health coverage and leaving no one behind, populations that have historically been left behind must be brought on board from the very onset. And as we've seen, the marginalized populations where women and girls are falling must be brought into perspective. And of course, the issue of the journey to sustainable development goal. And I'm glad that Ms. Sibanda has mentioned, SDG 3 and SDG 5. But let's also look about SDG 8, which talks about decent and economic growth, SDG 10, which talks about reduced inequalities, and SDG 16 that talks about peace, justice, and strong institutions. If you look at all these SDGs, you realize that a third of the SDGs then cannot be achieved if gender aspects are not mainstreamed or unintentionally addressed. That is a huge percentage of SDGs. A third of it are aligned or are looking at can only be achieved if gender aspects are considered. So all these health needs, and to achieve SDGs and UHC, the foundational place to start addressing this from is at the point of health research and development, and ensuring that the right tools and products are in the market and are timely accessible, and are of that optimum quality, are safe for use, are effective, they are efficient, and are able to address the inequities that exist, and are capable of being person-centered. The issue of person-centered is one thing that we need to consider within the R&D. So to better understand the various R&D phases, because we have about 8 phases that are globally aligned, to better understand that, I would like to speak about, 5 of the 8 within the R&D phase that we must consider integrating of mainstreaming and gender in them, as well as other aspects of DEI. The first thing that I would like to speak about is from the products identification phase. And the question to ask at this phase is, what products are getting developed? And is engaging gender diverse and marginalized population in the identification of these products happening? So we recognize that gender has increasingly been factored into health research as a result of the ongoing conversations, such as the one we are having today. However, much remains to be done. especially issues of women and other gender identities and expressions, are still largely underrepresented in health research and development, leading to limited data on risks and benefits of tested products, which later impacts on the ability to benefit from products gotten out of research. Intersecting factors such as, pregnant women is often left out in clinical trials. Gaps in research involving pregnant and lactating people has been a marginalized area. And from the DEI perspective, I would include here LGBT inclusion. Inclusion in terms of their perspective has also suffered the same fate. We have seen products, especially in poverty-related and neglected diseases, being designed without engaging the affected population and communities, and taking a human-centered approach or design to account when developing these targeted profiles. We see, or we have seen this classical example during the COVID-19 vaccine development. The populations most affected or that were most susceptible to severe disease were pregnant women. However, during the initial phases, these populations were not initially part of the clinical trials. And it was only out of the morbidity and mortality data that were later realized that out of COVID-19 infections, that it was realized that COVID-19 was so unforgiving to this population. This led to, rapid clinical trials on women and pregnant mothers. We can even mention several other examples in COVID-19, including, the issues of thrombocytopenia, or what we commonly call the blood clot effect, and how this later informed more research. So the key issues to ponder about at the product identification phase would include, whose needs and priorities are driving the identification of product development needs and the associated R&D investments. How do R&D investments incorporate sex-based differences and other gender power aspects underlying, choices about R&D investments? The biases or knowledge gaps in understanding the sex-based physiological differences and gender-related patterns or gender-related diseases exposure may limit, our ability to properly prioritize and advocate for health innovations. The other question is, how does not leveraging the perspective and insights from diverse technology products and service designers whose lived experiences and needs should most, directly inform solutions. Those innovations may miss this mark. As by examples, as has been highlighted, pregnant and lactating mothers have been excluded from opportunities that would have benefited from new technologies due to the exclusion of this population at the very onset during research and clinical trials. The second part that I will talk about in the product development phase is the product design and development. And the question to answer at this phase is, what are the equity dimensions of participation in the R&D ecosystem? Who is driving the R&D product design? And to answer this, the talent and the potential for development of product for public health global goods are not an exclusive domain for specific sex or gender or identity or other characteristics of individual groups. Yet many a times, the opportunity to conceptualize these opportunities and actualize them and to actualize those talents and potentials are associated with, the power, the financial, especially the social class, the power based on equity and gender norms and discrimination. The specialized training and networks and capital are not equally distributed, and marginalized groups do not necessarily have the equitable access to these inputs. Evidence has also shown that, there are more male in, science, technology, engineering, and mathematics, what is commonly known as STEM, the STEM fields. So the fact that we have more male in STEM than female also affects the kind of products that come out, or even if products come out, then you find that there are biases because the right people, the consumers of these products, are not necessarily involved in the production, in the thinking of these aspects. This is important from the rights perspective as well. And we saw that, from the South African legal perspective, health is a human right perspective, is a human right. So the barriers to the full participation of women and marginalized groups in STEM fields, are linked to the inequitable gender norms and discrimination in research and development. And in my personal view, this is the most important reason for examining who is driving the design for R&D. So the biases and discrimination against women in STEM work has a lot to do this, and also the biases and discrimination against LGBTI individuals in STEM. However, there is evidence that it is also important from the R&D business perspective in terms of attracting and retaining the best R&D talents. Study by a consortium of universities in the US, examined, among others, things, the role of LGBT in supporting policies in organizations who engage in highly skilled, knowledge-based work. And what they found out was that organizations which adopted policies that encourage LGBT employees to bring their whole selves to the workplace signaled that they were an employer of choice for all employees, thus enhancing a firm value, productivity, and profitability. The study also points to this trend being strongest in organizations with R&D activities. Similar studies have also shown that institutions with women in the leadership positions seem to be doing better than those in contrary. The third thing that I would like to mention here is from the product regulatory perspective. And the question to ask it, what are the gaps across the pharmaceutical research and regulatory pathway? And evidence is increasing of the influence of sex and gender on the wide range of health interventions, including pharmaceutical safety and efficacy profiles. Major regulatory agencies across the globe, especially in the US, Europe, and Canada, whose approvals often influence other countries, have made some positive but fragmented efforts to include sex and gender in pharmaceutical regulations. Women representation remains low in clinical trials, particularly in phase 1 clinical trials, where we are seeing barely 22% inclusion of women. In recent global efforts to benchmark national pharmaceutical regulations, standards, and considerations of sex and gender have been omitted because of, this benchmark needed to have considered, the women and gender consideration, but we are seeing that this has been omitted. So to strengthen gender responsive research and regulation to support women's access to appropriate medicines and health technology, the global health R&D regulatory ecosystem must consider certain issues. One, the greater attention to sex differences in target identification, stronger journal enforcement of sex disaggregated data outcome, more women in leadership and decision-making roles, of enforcement and penalties, global performance indicators that include, attention to sex and gender, more women committed to gender equity and equity in leadership and decision-making roles, and of course, issues of industry awareness and buy-in and capacity for prioritized investment in areas of unmet needs. And of course, the issue of global research agenda setting and product priority list. And lastly, issues of more women committed to gender equity in industry leadership and strategy. And of course, the last part that I would like to talk about is at the product access, at the consumer level. So we see that at the consumer level, having equitable access to R&D relies in part on having equitable access to information about it. So questions to ask in this phase would be, are there gender considerations in communication around R&D? Are there gender barriers in R&D communications? Are there gender-specific barriers in respect to culture, physical distance, and other gender-specific social determinants that needs to be addressed? Some of the do's and the don'ts that I would like to borrow from a UN OHCHR policy guidelines that was specifically looking at persons and disability that you can borrow and put in here are the following, especially the do's. One, we need to support dissemination and sharing of resources, data, research, and technology that promotes the inclusion of persons with disability and also women and girls' inclusion across sectoral and public and private divides. The other do is ensuring that all information and communication regarding research and innovation is provided and is accessible in formats that is inclusive in its content. The don'ts, or some of the don'ts that I would like to mention, two of them, is one, we need to stop assuming that persons with the disability of women or women to this matter will be able to access information on research and innovations without adapting this to the diverse populations that we are targeting, inhibit or overlook opportunities for the sharing and dissemination of knowledge and technology and research that promotes inclusion. At this point, we need to make sure that the research, the data that comes out of it must be inclusive enough, especially to the population. Beyond this information, what are the gender-related barriers to accessing these new products that are outputs of R&D inputs? Then investments, issues of gender inequities in accessing diagnostics, issues of how well do R&D investments consider context-specific gender-related barriers and products in designing the innovations. So to come to our discussion today, how then do we frame gender and DEI in R&D? And I would like to quote Singh et al., where they offered some gender frames to 5 key processes to state around research and development for product development within our context. So the first thing they mentioned is we need to prioritize funding for science that addresses the health needs of women, which is very important. We need to devise gender responsive technology. I see my time is almost up. We need also to ensure that gender equity in clinical trials is something that we consider as a proactive thing every single day, and accelerate the process of integrating the gender and the wider inclusion lens as an essential product development process to increase access to health innovations and save more lives. We need to adapt a range and create innovative approaches to commercialization of strategies for women. We need also to enhance access, both physical, financial, social, and any other barrier to healthcare and service delivery for women. So in conclusion, some of the questions I would like to leave us with and to ponder around as we move towards agenda and DEI integrated R&D would include, how do we look at the framing for gender and DEI considerations in South Africa? What is the missing link? And what is missing from the existing frameworks? What needs to be updated? What are some of the things we have currently, but needs to be updated. And what is the current state of the gender and DEI consideration in South Africa in respect to R&D ecosystem, specifically, and what would it take for all of us to make this progress moving forward, especially in this area of health research and development? I conclude. Thank you.
Thank you so much, Mr. John Paul Omolo, for an interesting presentation. Again, I'd like to remind you all to please put your comments and questions in the chat or Q&A function, or to use the raise hand function to directly ask your questions or share your comments with our panelists directly. Our team will make sure that we address all the questions and comments that you put forward. And last but not least, we are now going to hear from Professor Hedi van Ruan, who is the Group Executive of the Impact Center at the Human Sciences Research Council in South Africa. She is also currently the Acting Deputy CEO for Research at the SHRC. Her 28-year professional career spans government, higher education, and the Science Council environments. Hedi is a social scientist and a clinical psychologist holding an honorary professorship from the University of Witwatersrand, a member of the Academy of Science of South Africa and its Standing Committee on Health, and is one of the few social behavioral scientists recently appointed to the revised Ministerial Advisory Committee to advise the South African government on COVID-19. She's an internationally recognized and accomplished scholar with an NRFB rating, and sits on various leading groups tasked with addressing key regional and global HIV prevention and development issues. Her research work has addressed HIV risks and vulnerabilities, as well as the broader context and inequalities that shape this risk, the influence of sexual orientation and gender identity as social determinants of health, and issues of race and identity. Professor Hedi is going to talk to us about equitable access to health products. Over to you, Prof.
Thanks very much to the organizers for inviting me, and Nandi for the introduction, and to my two previous speakers, Nhlanhla and Jean Paul, who I thought raised some really important issues that I think in my talk I will be underscoring. So thank you. It feels like an important, bigger conversation. I want to just share my screen, if you'll just give me a minute to do that. And if you can see, can you all see my screen?
Yes, we can.
Right, perfect. Thanks very much. So I'm going to talk about equitable access to health products, equitable access to health products. It feels like a somewhat narrow conversation just to be talking about products. And I thought, to allow me to kind of get there, I want to make kind of three main points. And in many ways, as I was saying, in making these points, I'll be underscoring and emphasizing some issues that have already been raised by the two speakers. I want to touch a bit on health. I want to touch a bit on gender, and talk about what our contemporary framings are of both gender and health, without kind of repeating some of the points that have already been made, but particularly look at what some of these contemporary framings mean for the field of cancer research, which many of you are in, and talk about it also much more generally in terms of what it means for other health issues that we are facing. And then I want to kind of end off with this conversation of what does it mean for access and why access matters. So to kick us off then, just as an opening slide, I think both speakers have talked about this, particularly John Paul, talking about health equity. Health equity is a state in which everyone ideally could attain full health potential. No one is disadvantaged from achieving this potential because of social position or any other socially defined circumstances. And as we look at the kind of map of the globe in front of us, we know that social conditions conducive to good health and access to effective healthcare modalities are available, not to everyone equally, not to everyone in the same way. And in fact, these ideal conditions and healthcare modalities are available only to a small minority of the world's population. We are a long way from achieving the kind of equitable access to health that we want. In fact, the reality is that around the world, an increasing number of people are displaced into a precarious state of life. This gives you a sense of universal healthcare coverage, ways in which we try and measure a country's ability to provide essential health services to its population. And you can see by the different kinds of shadings, we tend to think about universal health coverage using 3 broad indicators: infant mortality, age-adjusted death rates, and life expectancy. And you can see by looking at this, again, the map of the globe in front of you, at least half the world's population lacks essential health services. The different colors in blue give you an indication of life expectancy. And the longer one's life expectancy, the argument is, the better your country is able to provide those basic conditions, societal, socioeconomic, environmental, health-related, those basic conditions to enable you to live a long and thriving life. And if you look at South Africa, it says life expectancy on average in South Africa is around 62 to 69. And you might think not that bad, but I think increasingly we know around the world, people are living longer and much more healthier lives, up to 80s or 90s. And so the big kinds of questions for us are, what is it about the conditions in which we live in these low and middle income countries that make it impossible for us to live longer, more healthier, sustained lives? Middle income countries around the world are challenged by a couple of unique factors. Inequities in health, as we talked about, and we know that very well in South Africa, for example. We live in a very unequal country with a private healthcare system that can only be afforded by a fairly small percentage of middle and upper class people, with the majority having to make use of public health systems. Our attempts in the country, from a policy perspective, we haven't quite got there to have a broader system of national health insurance as an attempt to try and imbalance some of these inequities, an attempt to try and make the basic provision of good health care services equally available to all peoples of this country. And I think you'll all agree with me that we are well far off that mark. And in fact, one of the other things that kind of shapes and shouldn't, one of the things that shapes access to health and ability to use and get good healthcare is one's economic state of affairs. And we know that increasingly what happens, those of us who are able to buy good health, have better health outcomes, can make sure that we get better kinds of service. And again, it's one of those fundamental conditions that we want to have to shift and change in this country. Alongside things like high unemployment levels, variable infrastructural development, we have these 2 different systems of healthcare: decentralized healthcare system, an attempt to try and get health services closer to where people are. But again, that suffers with other kinds of inequality. So more urban centers, much more likely to get a better set of primary healthcare than those in much more rural spaces. So again, those people who are further away in more rural communities, more vulnerable populations, for example, still not able to get the kind of healthcare that they need, or a particular quality or standard of healthcare that is desirable for good health. And then typically in many of our countries, in low middle income countries, we don't often have really good data which allows us to have the evidence we need to develop appropriate policies and programs for all who might need it. And one of the really key important points I want to be making in this conversation today, in thinking about health products, is in many ways a kind of challenge. And the challenge is, it's really important. I think one of the things we do is we kind of go to products, whether that product is a PrEP, antiretroviral treatment, drugs for TBs or cancer treatment. Many of us in the space of health kind of latch and put our attention on trying to find what I often think is the magic bullet. If we can find the drug, if we can find the thing, that's going to kind of help us address all these kinds of inequities that exist in our communities. We'll find this wonderful product, people will take it and people will use it. And I think Jean-Paul in his comments earlier on was making it really clear that people won't just use things, and that pipeline, that production line at various points, there's certain kind of problems in that production line that have to be addressed if we want people to ultimately take them up. We are saying quite strongly in this conversation today that gender is a key determining factor that influences whether or not you take up a product, and certainly what kind of life and what kind of outcomes you will have as an individual. This argument about the social determinants of health positions and makes this argument much more broader. And it says that we tend to think about health in very narrow biological terms. It's not just about the product. It's about a broader set of non-medical elements that influence health outcomes. And these really are the things that I've been alluding to already in the start of this presentation. These are the circumstances in which we are born into, where we grow, where we work, where we live, and our age. All of those factors, not just the medical elements or aspects, all of those factors determine and influence our health outcomes. And as we think about products and we think about access, we also have to be thinking about, I think, the extent to which we are also trying to address these other basic conditions that shape a life, that influence whether or not somebody's going to take up your product. And certainly on another level, economic policies, systems, developmental objectives, social norms, policies, as Notlandla was talking about earlier on as well. All of those things shape daily life conditions. And in South Africa, for example, we're particularly good at having good policies, but those good policies, whether that's around gender or that's around health, don't always filter into practice, into a lived experience that fundamentally changes the lived reality of someone. So the social determinants of health is an important frame. It has a significant impact on health inequalities between and within countries. And certainly what it shows us is that the lower socioeconomic status, the lower one's socioeconomic status, the poorer the health, the lower your status, the poorer the health. And we really need to be thinking about how we can address these broader social determinants of health. In fact, social determinants of health can have a greater impact on health than health treatment or lifestyle choices. These social determinants have a greater impact, and research is certainly increasingly showing us that they impact and influence your health outcomes. And so we have to be thinking about how do we address that. Now, health disparities in South Africa are significantly related to socioeconomic status, ethnicity, gender, age, discriminatory factors that reflect the ongoing long-term effects of apartheid. And so, yeah, who gets ill, what kind of life one lives are significantly impacted by these inequalities and about these factors that we're talking about today, particularly around gender. And our focus is on improving health through biomedical care, as I was saying earlier on, as the most important thrust towards reducing inequalities and equities in health is not enough. We have to be looking at not just improving the efficiency and effectiveness of existing healthcare services in the public sector, we also have to be thinking about how do we address these broader social determinants of health. And you might be saying as health practitioners, is that our job? Whose job is it? Is it government's job? Is it the job of NGOs, of civil society? I think it's all of our job. I think that if we tend to only want to focus in a very narrow way on products, on usage, I think we miss this important thing. Until we fundamentally shift and change and put our efforts into these broader systemic issues, we're not going to have very different outcomes for our country, not by a long shot. I want to talk now about gender, and I'm not going to go into any of these in great amounts of detail. I thought Nonhlanhla covered these really well, really making the point between sex and gender and trying to help us understand how these might be different, and that gender relations really describes the norms, values, and attitudes and expectations of how we should behave and how we are treated. This is a really wonderful artist, Harmonia Rosales, and she has some fantastic art that kind of looks at these two typical ways in which we frame women, for example. There's Eve on the one hand, and there's a Virgin Mary on the other. And if you are female or know any females, then you would know how often we kind of push women into these two particular kind of roles. So either an expectation that as women, we should be obedient or pure, long-suffering and silent. And our patriarchal society kind of enforces a kind of image of us as women in this particular way. So that's the Virgin Mary. And then there's Eve. By the way, my second name is Eve, who is disobedient, sexualized, a woman who dares to question, to challenge. The woman we are taught had Adam, and thus all of mankind kicked out of the Garden of Eden as a result of her non-conformity. So these gender just gives you an idea of some of the ways in which we frame what it is to be a woman and to be a man. In this case, just a woman, and then thinking a bit more about how that impacts on health. Now, again, we've touched on this sexual and gender minorities. Nonhlanhla talked about those, I thought, in her talk quite well. Heterosexuality is the norm, the understanding that one always and will only be attracted to somebody of the opposite sex as yourself. And we know that that is increasingly shifting and changing. And anyone who falls outside of this kind of narrow binary view of sexuality, of sexual orientation, of gender, of sex, is often then open to stigma and discrimination for falling outside of what is the norm. The norm as we uphold it is man and woman happily ever after, white picket fence, 2.5 children. Those of us who have different sexual orientations or attractions, who identify in different ways from the sex that we were by which we were born to who we and how we see ourselves as living, breathing adults now, often do struggle with this broader binary way in which we think about sex and gender. And so contemporary framings in the last while have really challenged this, and I've really talked about there's a much more complex relationship between sex and gender. And again, we talked about that earlier on, and that sex and gender interfaces with these other social determinants of health that I talked about that might make people even more vulnerable to particular kind of health outcomes than others. And so this idea that we complicate this relationship, it's not as simple as one that's really important for us to be leaving with as we exit this webinar today. So in cancer research, for example, we often emphasize preventable, modifiable, individual level behavior. Our risk-based cancer screening programs address various non-definable determinants like age, race, family history, genetic factors. But often what it means is that broader social and cultural gender-based factors are not addressed. So broader social and cultural gender-based factors are not addressed in this framing of cancer as preventable, not modifiable, focusing on the individual level. So issues like that might well be determinants of cancer, issues such as income inequality, social capital, social roles, unemployment, and other gender-mediated social factors that can contribute to pathways that determine health outcomes, including cancer outcomes, are often not addressed when we just focus on this risk-based cancer screening program in the way that I've described. And so I think sometimes if you think about some of the ways in which we think about cancer prevention and treatment, it often feels as though our work is a little gender blind. Cancer prevention, screening, and treatment approaches are impacted by systemic, I think, misunderstandings of sex and gender. And so, for example, we uncritically talk of women's cancers. We talk of women's cancers, and so doing that, we overlook the diversity of experiences of cancers among both older and younger sexual and gender minorities. And when we talk about it as women's cancers, just really focusing on the idea of sex and not of gender, we overlook the diversity of experiences of cancers among both older and younger sexual and gender minorities. So biological sex then, in this framing, when this thinking about cancer prevention and treatment, biological sex is the primary driver for women's cancers, rather than being based on particular anatomical elements such as a breast, a cervix, or ovaries. And so when we kind of think about just biological sex, what do you have as a way of kind of framing who do we treat and who do we screen and who do we approach? We miss some of these anatomical factors which might exist for somebody who presents as a male, for example, who's a transgendered male, but might actually have some of these physiological features that would put them at risk for cancer. So a person's actual gender identity and expression may obscure the need for cancer screening. So really important, I think, that we think about this. We kind of hold some of this difference between sex and gender in mind, that we don't just narrowly focus on sex as a criterion for screening, and that we begin to think about that the ways in which people might present or their gender identities might well be different from how they were physically or from their sex at birth. And that if we don't kind of bear in mind that complication, we will miss many people who are transgendered, and if it, particularly in this case, transgendered men who may have been female at birth. So this emphasis on both sex and gender is really important in thinking about risks for cancer. So I did some work a couple of years ago with a group of transgendered females, and we talked a bit about trying to understand these issues that we're talking about of gender and of sexuality, and of what it means to be a male or female, or to be living in a particular body. And I want to just read this poem. And so we based on our focus group discussions, we then developed a series of poems. And I want to read this poem from a group of transgendered women about this male body, and to help you kind of get a sense of some of the struggle of who I am and how I present with it, my gender and what my body might be are two different things. And we have to hold that complexity in mind as we do this work. And so the poem is called This Male Body. We are aware that we are male-bodied, but we struggle with ourselves, trying to accept this male body we have been blessed with. The woman inside me is sexually stronger. The moment a guy starts to touch certain areas of my body, I need to leave. Or if you're in my space, I will tell you, you need to leave because I feel disrespected. I feel so low when a guy goes down there, turns my mood off. In that moment, I'm like, oh my gosh, what the hell is this guy doing? If he says, just let me suck you, I'm thinking, just let me get my clothes and get out of here. I'm not going to do this. I'm not a man. I'm a woman trapped in a man's body. I am not a man. I'm a woman trapped in a man's body. And so contemporary framings ask us to kind of think about sex and gender in different kinds of ways. And ask us to understand cancer risk screening and treatment, for example, requires, we think, further integration within public health practices to ensure a much more nuanced approach to cancer care program development and implementation as a whole. And we think a key to this is to a thorough understanding of the many intersectional approaches to gender in relation to cancer risk and care, and the many intersectional approaches to gender and whatever your kind of health issue is that you're dealing with, whether that's TB, whether that's HIV, whether that's COVID, or whether that's cancer. And this intersectional framework really tells us that risks and impacts are shaped, by intersecting factors like sex, gender, age, health status. These things kind of impact and they kind of are interrelated and sometimes compound for an individual, worsening or lessening somebody's kind of risk. And we have to understand these intersecting, influencing factors from geographical location, disability, migration status, race, ethnicity, and socioeconomic status, and how they present and come together into the life of a particular individual as we think about our treatment and prevention programs. That factors at individual and group levels are shaped by broader processes and structures of power, that creative interplay of advantage and vulnerabilities. And some of us are more vulnerable, less vulnerable, depending on the interplay or the intersection of these various factors. This kind of framework of intersectionality allows us to capture experiences of different groups and recognize gender as an intersecting component of wider structural inequalities. It also offers us a critical, conceptual, and practical rethinking of public health responses that can help resist against static framing of inequality and disadvantage. So it really says the ways in which we think about inequality and disadvantage is very different for a Black, rural, transgendered, let's say Black rural woman, or a Black transgendered urban person. All of those are very different things, and how these factors come together and exist in a particular life will influence to a greater or lesser extent the ways in which that person would be able to access, uptake, and use your particular kinds of products. And we have to consider that complexity again, as I was saying earlier on. I'm kind of getting towards the end of my talk, and I want to just end down this fourth point I want to make, which is about equity and access. To achieve equity in healthcare access, numerous factors must be overcome. This includes equity in service delivery, equity in health funding, and financial risk protection. And so on your left-hand side, you'll see equity in service delivery, and equity in financing and financial risk protection. We talk about both supply and demand factors, a slight error in that middle right-hand box, that should be demand. We talk about differences, and we have to kind of think about both supply and demand side factors as we think about how do we create better access for our products. On the supply side, we have to look at how to achieve equity in service delivery so that everyone has access to the right number of well-resourced services. So does your transgendered person come into a clinic? Do they have access? Does your male or your female have access? What factors might influence whether or not somebody is able to access some of your services? And so we know things, for example, like costs and convenience. For example, for a woman, may not always have, might have less finances than her male counterpart, may not always prioritize her own health over that of the children or others in the household. And so that might influence and impact her ability to access whatever your product is. On the other hand, for a male, for example, it might be different. Access is often made available and provided in the context of an 8-to-4 health system that might limit the ability to kind of access your particular healthcare. So we have to consider both factors in both the supply and the demand side, and ensure that we are achieving equity in health, finance, and financial risks as we go along. So consider both supply and demand factors. And so when thinking about access, we have to think about equity in service delivery and health funding. As I said, we have to think about optimal and equitable resource allocation, physical accessibility to both preventive and curative services, health-related human resources. And so are those who are tasked with providing healthcare, is there an acceptable amount of skill mix, is that the right qualities? Are those health services being distributed fairly across rural and urban environments and settings? And we also have to focus on quality, safety, efficacy, and patient-centeredness. And Jampo also made that particular point. For gender and sexual minorities, there often is a reluctance to seek healthcare. There's ways in which healthcare might be avoided because there are fewer opportunities available to them, because there's a sense in which that who you are as a gender and sexual minority might be stigmatized or discriminated against, as I said earlier on. And so if you are avoiding healthcare system because you're afraid about the kind of attitude or response that you might be getting, it's likely that you won't be benefiting from prevention messages. You might not be screened for illness and infections. We might be missing you because we are talking to our understanding of sex and gender. The example is very much a heteronormative one. We're not making space and allowance for people whose sex and whose gender might be quite different. And it means that we may not get to you in time, and we may not intervene in a timely fashion. And so these kinds of gender and sex issues that gender and sexual minorities experience with relation to access might result in reduced overall wellness and certainly possibly greater mortality and risk. So this is the last slide I really want to leave with. As I think about my work, as you heard, covers HIV, it covers TB less so, but certainly now increasingly thinking about COVID. And I'm thinking about some of your work in screening and products for cancer. And I think essentially the argument is the same no matter what your health intervention is, no matter what your product is, the thinking is the same. I think often a lot of our focus is placed in that middle block at the individual. So much of our work and much of our attention is individual focus. I think Jean-Paul made some really important cases in thinking about that whole loop of product design, products for people. We don't involve the individual as much as we should. It's designed by us because we think based on our studies and our efficacy studies that this is a particular good product. This is what the field tells us is needed by rural women in South Africa. And we build these. Often in our building of products, we create products. We don't often include people enough in the building and the development of those products. And then we create the product and we think magically people will come just because it's good. So we think magically people will use the vaccine. And what we've seen is uptake of that vaccine is not as simple as we thought, because access and uptake are influenced by a range of factors. It's not just about just the product. It's influenced by information, by knowledge, by motivations, attitudes, and beliefs, and an ability to act. Really a sense that I am able to act, I am able to access this product. We've done some work, for example, on vaccine hesitancy. And the issues were really interesting. People were saying, I'm aware that the vaccine's there and that the vaccine might work for me, but in my context, I'm sitting with 20 Rand that separates me from starvation and my family from starvation for the rest of the month. I'm not going to spend that 20 Rand on getting myself to a clinic to be vaccinated. I'm rather going to take that 20 Rand and provide food for my family. So even though somebody has the knowledge and information, might well be motivated, the ability to access, to take up that product are influenced by a whole range of these factors that would influence the ability to act and to access and to use a particular particular product, as well as these broader kinds of norms around gender that we talked about earlier on. And so I think somehow we fall short because our focus is only on the self, almost in isolation of these other intersecting layers of influence. What's happening at the level of partners and families and peers, and how what others think influences whether or not I'm going to make a decision to take up a particular product. What happens at that interpersonal, personal, relational level? What's happening at the level of community in our organ and at that broader kind of level? And what is happening and how do we at that level of NGOs, CBOs, and government and other providers really work together to kind of enforce and encourage uptake and use and accessibility of our products? And certainly that broader policy and enabling environment, which Nonflanfla talked about, has also to be supportive and conducive to good health behaviors and our ability to take up products. So I'd like to leave it there, and thank you very much for your attention.
Thank you so much, Professor Hedi, for such a powerful presentation. And then I'd like to thank again Mr. John Paul, as well as Ms. Nhlanhla Sibanda Moyo for very inspiring and great presentations. I'd like to open it up now to our attendees. This is a chance for you all to ask our panelists questions related to their presentation. And we've already received, there's a question directly to Professor Hedi on the chat from one of our attendees. They'd like to know, how do they pick up your presentation and transform it as an academic research in Kenya, targeting the pharmaceutical and health business companies? They'd like to follow up, they'd like a follow-up session with you on this. Any comments on this, Prof?
Sorry, what was the question there, Nandi?
So they'd like to, so they want to know how can they pick up your presentation and transform it into an academic session or into an academic research in Kenya, targeting pharmaceutical and health business companies. And they'd also like to have a follow-up session with you on this.
Yeah, sure, very much happy to do that. And so maybe just to, chat to me privately there, send me your email address. I'm happy to pick up the conversation. And yes, I think the organizers will make the presentations available to those who've participated. Yeah, and I'm happy to make sure that.
Thank you. To kickstart some of the questions, I do have a question that is more sort of health product specific, but is related to equitable access. So, and I guess it's directed to Professor Hedi. So Professor Hedi, we know that the pivotal vaginal ring is a ring that has been proven efficacious for women to use in preventing HIV infection. And, we've heard in March 2021 that the World Health Organization released new clinical recommendations on HIV prevention, which included detailed guidance for the pivotal ring as an additional prevention choice for women at substantial risk of HIV infection as part of a combination prevention package. So, it has also received, it was also recommended by the WHO as an additional HIV prevention option for women, and has received pre-qualification as well. We recently heard that it was, it also last year it also received a positive opinion from the EMA and was recently approved in Zimbabwe as a prevention method for cisgender women. So I'm just interested, Professor Hedi, from you to, I'd like to hear your opinion on how far you think South African women are from accessing this important products that may prevent or help them prevent HIV infection. And to Mr. John Paul, I'd like to find out from you, how can civil society and advocates sort of advocate for an expedited approval and development of the pivotal vaginal ring in South Africa so that women can start using it ASAP? Again, this is more product specific, but looking at equitable health access to proven products, as well as advocacy around what civil society can do to make sure that that product gets to the people that need it the most. Thank you.
Sure. I'm happy to kick us off. So thank you for the question. I think, so some interesting, as you say, you list all the various people, the studies which say this is efficacious for HIV, and that it should be taken up and rolled out and implemented. And yet we look at some of the data and it looks like the roll up, the implementation of it is taken longer to kind of take off here, for example, in South Africa. And why is that so? And I think some of the work that we've done earlier on in trying to understand barriers to uptake around some of these HIV prevention interventions are probably true still in this particular circumstance. And it is around products have to, in order for products to be used, they have to have a meaning in someone's life and in their routine. And I think often when we ask women about what is top of your mind, what are the things that you are worrying about? The things that they are worrying about are actually not HIV. We think they're HIV because we work in HIV. We assume that they should be HIV. The things that women might be worrying about, for example, more of a priority might be safety, might be a concern about rape, would be a concern about gender-based violence, or would be a concern about employment and work opportunities. And I think the point I'm making is that in order for us to understand or to try and drive uptake of whatever the product is, we have to kind of, I think, have a better sense of what meaning somebody makes of that product. How does this product fit into their life? Because if we don't understand that broader context of someone's life, we won't find the right kind of ways to kind of hook our message. We won't kind of find the right kind of ways to talk to that woman, to kind of begin to find a way where she can consider how and in what way she can take on a particular kind of product. So I think often the work on products has to go a little bit broader. It has to understand context. It has to understand how women make meaning in order for us to kind of then think about how do we get our messaging right and how do we get our interventions into the hands and being used by these very women. We have to understand their broader context.
Thank you. Professor John Paul.
Thank you so much. I think in terms of, how can the civil society advocate for, one, the approval, the regulation that's at the regulatory piece, and then the access. I think I would like to borrow from what happened during the phase of the DTG. I think we are aware of the DTG combination for HIV, which is a new regimen. I would call it new, but not very new because it came into force even in countries like Kenya a few years ago. But it took a number of us as civil societies to continuously engage our governments to accept them into the new clinical trial, guidelines, and as well as the investment by domestic investment for these medicines. So what did we do? One is we packaged the evidence that has come out of the clinical trials, not only from populations that are outside the African continent, but we ensured that we used data from, a similar gene pool, because it is important that we continuously look at clinical trials that are being done within the gene pool that is similar to what our context looks like. And then we used this kind of information, packaged that evidence, and used it to engage decision makers, what I would call the champions in this case, because within the champion phase, we have decision makers and policy makers. So we engaged most of them with this information. And this was a deliberate process that we undertook within a coalition. So the other thing that I wanted to mention is coalitions such as SATAC needs to come into force and continuously engage, because many a times when an individual organization engages a decision or a policy maker, then they start thinking this could be a path thing, this could be an AVAC thing, this could be an IAVI kind of an agenda. But when coalitions come together, they understand that this is an agenda that is being pushed by a consortium or a network of individuals that really feel that this is important. And of course, when thinking about it and engaging these decision makers, we do not only think about the health aspect of it, because are we able to show that the risk, the benefit outweighs the risk, both from the health side, but also from the economic side of view. I think we all understand the benefits that came up with the DTG as a new drug, both from the health and economic point of view, being that, it is a single drug as opposed to the multiplicity of drugs that were being taken prior to DTG, and the fact that all this has an economic benefit to it. So we need to wear that hat and take lessons, not only document lessons, but learn those lessons and take them up and use it in this vaginal ring technology to engage our decision makers, so that one, we increase the uptake, not only uptake, I'm talking about the regulatory processes, because when we engage the regulators, both at the country level, at the regional level, and even at the continental level, now that we are going to see AMA come into force in the next 30 days by 5th of next month, we should be able to start engaging this kind of regulators, so that when such technologies come into force, we are in the front line of engaging and providing them with the right data and evidence for use. And of course, now from that point, we also need to start engaging other communities that are going to use this. When we have enough voice by the communities, the users of these new technologies, then decision makers and policy makers will listen. Over.
Thank you both. One of the other questions that has come up is, I think, directed to Mr. John Paul. So when is the civil society or the most marginalized or vulnerable populations engaged in and involved in the product development process? So what can civil society and advocates do to ensure that the voices and priorities of the marginalized and vulnerable populations inform the development process of health products and technologies?
That's a very important question, and thank you so much for the person who's brought it up. There are many things that could be done. And I think the first thing is creating forums such as the one we are having today and inviting the community on board. Because many a times we don't do things because of the ignorance. We do not know our right. But until you know what it is that is within your right, you are not able to ask for it. And the classical example, as was raised by Professor Hedi, is many a times we assume that people need some product or some interventions. But when you go down on the ground and ask them what their need is, then you realize that you are off track completely, because maybe someone's greatest need is food, and you want to give them a drug that would treat their problem or their illness, but that drug needs some energy. So at the end of the day, this individual will not take their medicines or their prescriptions as described, simply because they also need to contend with the effect of the drug, because the drug needs energy to have the full effect. But they have also to look for food. So before you address their health need, you might want to address their food needs, or their, something like that. So at the end of the day, this needs to happen. So how then do we make sure that the voices of the people are in place? We need to work with research institutions to continuously inform them that within their research, ethical research committees that approve those researches, are they having a community voice in there? How often are these results being disseminated to the communities? How much is the community voice, especially when they speak, incorporated into the research protocols moving forward? And how much is that informing the final product that comes out? So that at the end of the day, from the research point of view, we should be able to understand that whatever we do in the lab is never as good as it would have been when we have incorporated the voices of the community. We must make it deliberate, both from the legislative point of view and also from the policy point of view, that, the voices of the communities must be involved in anything that is going to affect them, including, system strengthening, because some of the times the health system strengthening is also affected by the way we behave, the way we are conformed by our culture and by our way of life. So how is that informing the way we produce products? We need to ensure that this is informed in the policy part, in the legislative parts of it, and in the practice of research and development. Thank you.
Thank you, Mr. Omolo. And last question is to Professor Hedi. So Professor Hedi, how can low and middle income countries ensure that efficacious or proven health products and technologies are affordable and accessible to people that need them the most in order to achieve equitable access of health products to all?
Thanks very much again for that question. And yeah, I think it is about priority, and it is about having policies that support the provision of all kinds of health products to its people. And we see in many ways in South Africa kind of a failure, in some ways an attempt to try and do that, but it feels like the money goes on all other kinds of things. So I think that's the first, is a priority by governments to kind of say health equity is a basic priority, and that we would prioritize that over spend on wars or all other kinds of things. In our case in South Africa, spend on corruption. So that's the first place, I think, a kind of a commitment in our policies towards this equitable health, and seen it as a basic right, a non-negotiable right for all our citizens. And we are some way off that. But it does require kind of a reprioritization. I think also certainly the issue on vaccines or HIV drugs has also kind of taught us about, we have to be much more involved then in negotiating with companies who make drugs and who make products to try and ensure that we get drugs that are at a price that are affordable and that can be used by the majority of our populations. And so to be involved much more at that level in engaging and negotiating and fighting for and making drugs affordable and accessible seems to be an important part of what our health ministries also need to be doing. But I think it starts first with a kind of a commitment and a priority and a belief that this matters more than anything, alongside basic housing, basic water and sanitation, a right to good food. Those are our responsibilities as governments and as countries to provide that for all of our citizens. And I think here in South Africa, we've fallen short on getting some of those basics right, as well as basic healthcare for all. There are attempts, as I said, in the national, in the NHI system, but we just haven't been able to kind of get that moving and get that going. It's going to require cooperation too. So it's not only government, and I think that's a point Jean-Paul makes well in his comments, and it requires a commitment from all of us too. Government has a part to play for sure, but private sector, industry, communities, community organizations, we all have a role to play in ensuring that we provide access and helping people get over the barriers and making sure people get the basic supports that they need to enable good healthcare. And we all have to be asking ourselves, what is my role? What is my responsibility? Can we be doing more to ensuring a better life for all of our citizens, whether that comes to health or to education or to a basic roof over our heads? What more could be done? What more could we do?
Thank you so much, Prof. I am mindful of time. We are 6 minutes over time. And we've received really great comments around the powerful presentations that we had from our three speakers. So in the interest of time, I'd like to invite Ms. Nonhlanhla Sibanda-Moyo, Mr. John Paul Omolo, and Professor Hedi van Ruan to sort of share with us their closing remarks as we look towards ending today's webinar. I'll start off with Ms. Nonhlanhla.
Thank you very much, Nandi. I really found it quite fascinating how Professor Ruan underscored the complex relationship between sex and gender, and again, the introduction to the intersectionality framework. And of course, the Virgin Mary and Eve imagery was quite captivating and telling. And just to build on a point that John Paul made a reference to earlier, in as much as there is fluidity in sex, there is diversity in the different gender groups. And men are not a homogeneous conforming groups, so they are not homogeneous. So we shouldn't be thinking about these groups as being homogeneous. And just to conclude, I think that there is a case integration of sex and gender as standard practices in health research and development. And I hope that as participants leave here today, they take on the important role of being advocates for diversity and gender equity in health. Thank you very much.
Thank you. Mr. Omolo?
Thank you so much, Nandi. I think first of all, just to appreciate the wealth of information that has been shared today. We are all learning every single day, and sometimes when we think about gender, you realize that it's gender in itself is a marginalized topic, and it's never thought about in so many ways. So I think the thing that I want to mention here is gender needs to be that and the integral part of the health system, and the health system strengthening, and all this starts with health research and development, because until we are able to come up with system products that are addressing our needs, we will not address the health challenges that we are having in the continent and across the globe. So until we mainstream and integrate gender from the very onset, which is now the foundation of health, which is R&D, we will not be able to achieve our goal of a healthy society and equitable health system, and accessible to the highest attainable standards of health. Therefore, with having understood all this, we must not only document these lessons, because I think in Africa we love documenting things, but we hardly learn from them and put the learning into practice, so that the learning informs how we behave and how we do things. So if we are able to learn from what we do and not only document them for the sake of reading, we must also put them as a way of practice, how, the way we do our everyday things, especially within the research and development. That would be my call for action. And if we have, 18 or 30 participants today in this call, or 30 plus, how can each one of us start talking about, integration of gender within health R&D as a way of practice and not a cosmetic way of doing things? Over.
Thank you so much, Mr. John Paul. And last but not least, Professor Hedi.
Yeah, thank you. And I thank you to my two fellow speakers today. And I want to just maybe end off on that last point that John Paul was making. I think and that's that call for kind of practice. And I think the call for practice is on two levels, in my view. It is on the level of how do we ensure in our workplaces, in our environments, that we have organizations that are inclusive with respect to gender and health, and that we adopt a broader framework of thinking about this, and that we hold the complexity of it. Because I think often, increasingly in our world, we all want to be returning to that which is simple, that which feels somewhat more narrow but manageable and within our control. And I think the conversation today has really been about complexities, about it's not homogeneous, it's not the same, and how do we hold this complexity of sex and gender in our mind. So that's certainly at the level of our organizations, at the level of our work. But I think often in conversations about gender, we tend to think about gender as something which is out there. And I really want to leave us with that realization and the point that actually gender refers to us too, in our own selves and in our own lives, in our own relationships, in our own homes, in our own communities. And the more we can kind of find a way of integrating our understandings of what it means to be a male or female, and the ways in which we live our lives as gender and sexual minorities, whatever it is, the more we can integrate and interrogate those very aspects of gender in our own personal lives, the more we do that, the more we're going to be able to kind of take that conversation in a much more meaningful way, take it forward in a meaningful way in our organizations, to create societies, to create institutions that are more inclusive of gender and diversity. Thank you.
Thank you, Prof. I think our expert panelists have said a mouthful. So I'd like to just end it off by thanking you all for joining us in today's webinar that was focusing on diversity and gender equity in health research and development. I would particularly like to thank our expert panelists, Ms. Nonhlanhla Sibanda Moyo, Mr. John Paul Omolo, as well as Professor Hedi van Ruan for their wonderful and brilliant presentations. And we also like to extend our thanks to the South African Health Technologies Advocacy Coalition, SATEC in partnership with PATH and Campaign for Cancer for organizing this brilliant session. Thank you all. And I do believe that the presentations and the recordings will be shared with all our attendees today. Thank you all, and we would like to wish you a very good day further. Thank you and enjoy the rest of your day.
Thank you. Really appreciate it. Bye-bye.